This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with prior written consent of the American Association for Respiratory Care. Copyright 2023, all rights reserved. My name is Joyce Baker, and I'm the Asthma Clinical Specialties Coordinator at Children's Hospital, Colorado. My background includes being a fellow of the American Association for Respiratory Care, a recipient of the ARCF Mike West Patient Education Achievement Award, and the FACES Foundation Phil Award. I'm a Board of Trustees Vice President for the National Board for Respiratory Care and an editorial board member for the Respiratory Care Journal. And I currently sit on the American Association for Respiratory Care Physician Review Committee. Welcome to today's program, What Can the SDS Credential Do for You? Upon completion of this AARC program, the participants will be able to review the history, development, and requirements of the SDS Credential, discuss benefits offered by the NBRC, and unpack ways the SDS can benefit RTs working in and out of a sleep lab. I am pleased to welcome Laura McFarland. Laura graduated from the North Dakota State University in 1999 with a Bachelor's of Science in Respiratory Care and has worked in DME, education, and management, but sleep disorders are her passion. She has worked in the sleep medicine field for over 22 years, training sleep technologists, providing staff and public education, leading accreditation efforts, and serving as the sleep lab coordinator. Laura was fortunate to benefit from several awards during college, which included the ARCF-NBRC Robert M. Lawrence Memorial Scholarship. This came full circle when she began volunteering for the NBRC 14 years ago as one of the first members of the SDS Examination Committee. During her time with the NBRC, she has been fortunate to serve on the Board of Trustees for 6 years and has chaired the SDS Exam, Specialty Examination, and Judicial and Ethics Committee. Laura currently serves as consultant to the NBRC SDS Examination and the CMP committees, while working remotely in sleep medicine and partnering with her husband on farming operations near Princeton, Minnesota. Neither Laura nor I have any relationships to disclose. Brand names of products and or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Laura, welcome to the program.
Laura, you're muted.
Can you hear me?
Yes, I can hear you.
Great. Thank you so much. Thank you, Joyce. I truly appreciate the opportunity to discuss the Sleep Disorders Specialist Credential today. As Joyce mentioned, I was fortunate to be the recipient of an NBRC-funded scholarship way back in 1998. This award included a trip to my first AARC convention, which made quite an impact on me as a student. And it is truly an honor to have the opportunity to give back to both the NBRC and AARC later in my career. There are 3 things that I feel very passionately about related to my career: being a respiratory therapist, the value of sleep medicine in healthcare, and the quality of the SDS credential. When I started in sleep medicine, there was only one exam available to display competence in sleep disorders testing, and I sat for the RPSGT exam. I assisted other techs and respiratory therapists as they prepared for that exam. But now, fortunately, we have another option as respiratory therapists, and I'm hoping that I've put together some information which will get you thinking about how the SDS credential could provide added value to your career. As Joyce mentioned, I have no financial disclosures. I do currently serve on the NBRC SDS examination and SDS Credential Maintenance Program committees. So we will cover the history and development of the SDS credential, the application and credential maintenance process, benefits offered by the National Board for Respiratory Care, and hopefully we will answer the question of what the SDS offers RTs, whether you work in or out of the sleep lab. First, we'll look back just a bit to get a very high-level perspective on how the SDS came to be. Respiratory disorders have been documented for centuries, as early as 410 BC in Hippocrates' Book of Epidemics. Symptoms of the flu were described in great detail. Fast forward just a few centuries, and we have the advent of oxygen use in acute care by the late 1800s. Early education programs were developed for inhalation therapists, as we were known, by the mid-1900s. And in 1960, the American Registry of Inhalation Therapists, currently known as the National Board for Respiratory Care, was formed to guide credentialing of this growing profession. On the sleep side of the timeline, REM sleep was first observed in 1953 by Azarinsky and Kleitman. And by 1980, Dr. Sullivan used CPAP to treat sleep apnea for the first time. This treatment option opened a whole new world for sleep medicine. And by 2014, over 1 million patients would be using CPAP in the home. During this large expansion of the field in the early 2000s, about the time I started in sleep medicine, sleep labs emerged from small to mid-sized RT departments that were hoping to utilize existing staff while offering a new service to the community. RTs were already present on the front lines. We became natural fits for sleep medicine. And by 2006, the AARC responded to the increasing numbers of RTs entering sleep medicine by submitting a formal request to the NBRC for a sleep credential. And we have right around 1,000 SDS credentialed RTs today. So how is the SDS exam developed? The NBRC uses the same 5-step process for each exam. Following a request from an outside agency, the NBRC starts with the viability study to see if there's an appetite for the credential. This moves on to a personnel study, which investigates if there's a sufficient population of candidates and if uniform practice standards exist. If these steps have positive results, a job analysis is completed to ensure exam content is relevant to current practice. These job analysis results drive the development of test specifications, types of items, total number of items, content areas, etc. These specifications, sometimes known as the exam matrix, ultimately guide each test form that is put into service for potential candidates. Down the road, a validation study establishes a direct statistical relationship between job performance and examination scores. So you can see where the surveys that you receive from the NBRC each serve a particular function in assuring high quality exams. This exam development process can stop at any point, and the decision could be made not to proceed forward. But if it is decided that an exam will proceed through the development process, that's not the end of the process. A new job analysis is completed routinely. This occurs every 7 years for the SDS exam, and this ensures that exam content remains relevant to current practice. One good example of a change that was noted in our last job analysis was the increase in sleep testing completed in the home. This will result in changes to our test specifications with more emphasis in this area. So you can see where this is an ongoing process for the NBRC. Each exam has a committee which is composed of RTs and physicians working in that respective field. Depending on the exam, we meet in person 1 or 2 times a year and complete additional tasks via web calls and meetings. Item writers assist by submitting questions which are reviewed and revised multiple times by the exam committees and then utilized as pretest items which don't count toward your final score until they demonstrate that they perform well. All of this is done to ensure that exams are the highest quality and predictive of job performance. This is actually a fascinating process, and the NBRC is a well-oiled machine. To give you an idea of the work happening behind the scenes of each NBRC exam, a new job analysis was completed in 2021 for the SDS Credential. And revised test specifications will go into effect later this year. So it's actually about a 2-year process. To complete this process, the NBRC disseminated surveys to over 5,000 individuals from 5 professional organizations. There were over 250 individual tasks from 5 content areas. And for the SDS, those are pre-testing, sleep disorders testing, study analysis, administrative functions, and the treatment plan. And responses were received from a wide variety of sleep professionals working in different areas and even other countries. The vast majority, over 98%, of our respondents felt the tasks adequately covered those 5 content areas. And we carefully reviewed any free text responses for additional input. One thing that we learned from this recent job analysis is that the trend toward sleep disorders specialists working outside the lab became very clear, and this shows how sleep roles are evolving over time. RTs have a great sleep medicine foundation right out of school. With an understanding of CPAP, bilevel, pressure support, supplemental oxygen, mask fit, patient education and coaching, pharmacology, DME, and much more, it's a natural progression to build upon this knowledge and become a valued member of the sleep medicine team. The NBRC takes this background into account and requires 3 to 6 months of work experience, depending on your credential, to apply for the SDS exam. If you have had the good fortune of completing a sleep add-on track approved by COARC, there is no work experience required. The fees for the exam are really quite competitive with other organizations. And there's an AARC member discount of $40 that I found on the website for first-time applicants. I noticed just this morning when I was doing some last-minute research that our competitor organization, the BRPT, is increasing their fees July 1st this year. Of the 180 questions that are on the exam, 20 are pretest items that don't count toward your final score, and 160 are the ones that actually count toward your final score. 4 hours is allotted for this exam. I've trained over a dozen sleep techs in the past 20 years, and they each brought a unique background, ranging from no medical experience to nursing, EEG technology, and RTs. I can personally attest that cross-training an RT into sleep was by far the easiest endeavor. There is just no replacement for that foundation that we receive in RT school. So once you pass the SDS exam, how do you maintain your credential? There are 4 options to maintain credentials earned through the NBRC. RTs have the option to document CEUs, like we were always used to in the past. You can complete quarterly online credential maintenance assessments, or you can complete a combination of CMP assessments and CEUs. RTs can also choose to retest to their highest credential or add a new credential. Since 2020, the NBRC Online Credential Maintenance Program known as CMP program, has allowed RTs to display continuing competence through the completion of quarterly, online, practice-related questions which are centered on areas that are high risk or high pace of change. One important benefit to consider of the SDS is the fact that adding this credential will not increase your credential maintenance fees. $25 per year covers all of your credentials earned through the NBRC, no limit. And the AARC has approved CEUs for completion of the CMP assessments. And this could be important for those working in an accredited sleep lab that have to document CEUs for accreditation. So why test? Why get a credential through the NBRC? Anyone working in sleep medicine for any length of time knows that there are other options for sleep-specific credentials. But since 1977, the NBRC has maintained accreditation for all of their exams with the National Commission for Certifying Agencies. This is important when regulatory agencies determine technician requirements for reimbursement of services. Not all sleep exams have achieved this accreditation. With around 25,000 candidates tested each year, the NBRC has built a strong foundation which allows the organization to give back to our profession. In addition to 7 long-standing scholarships funded yearly, a portion of each practitioner's $25 annual credential maintenance fee is donated to various causes through the Choose to Give initiative. In 2021, the National Sleep Foundation was chosen as one of 3 recipients. And last year, the NBRC donated more than $2 million in scholarship funds to accredited respiratory care education programs. And with the projected shortage of respiratory therapists, in 2021, the NBRC launched the More RTs campaign, a joint venture with the AARC and COARC to increase public awareness of this profession. No doubt many of you have seen or maybe even participated in the advertising campaign on social media. Customer service is a top priority, and the NBRC offers a live chat feature on their website, remote proctoring of exams, and the ability for your employer to purchase vouchers to cover exam fees. We've already mentioned the CMP program, but I can personally relay that as an RT who has held credentials through multiple organizations, resulting in memberships and renewal fees through multiple organizations, along with a state license. If the SDS had been available when I started in sleep medicine, it certainly would have been my first choice to simplify my credentials. To answer the question of what the SDS can do for you, let's focus first on the population of RTs already working in the sleep lab or clinic. For many years, holding a CRT or RRT credential while working within a Joint Commission accredited hospital was sufficient for CMS reimbursement of sleep disorders testing. But this has begun to change. Around 2015 to 2018, the Medicare Local Coverage Determinations, or LCDs as we call them, began to require either sleep lab specific accreditation or sleep technician specific credentials. Currently, as I took a look at these recently, of the 12 Medicare Administrative Contractors, or MAC, jurisdictions in the U.S., 5 require sleep-specific credentials of SDS, RPSGT, RST, or REEG to perform any sleep disorders testing. 2 require a sleep credential to score home sleep tests, which are quickly becoming the majority of our testing. And the remaining 5 MACs allow RT credentials of CPFT, RPFT, CRT, and RRT to perform testing, But each of those 5 MACs require the lab have a sleep-specific accreditation through the AASM, ACHC, or Joint Commission. So what does this all boil down to? This means you may still be able to work as a night tech in 5 of those 12 MACs with an RRT or CRT credential, but you may not be able to serve as the main registered day tech for the lab, as required by AASM accreditation, or possibly score HSTs without a sleep-specific credential. And this could make career advancement more challenging. State licensure for sleep technologists is another thing we want to consider. According to the American Association for Sleep Technologists website, there are currently 12 states with a Polysomnography Practice Act requiring sleep technologist-specific licensure. There appear to be a couple pathways in these rules for RTs. Some of them have the SDS listed. Many have more general verbiage accepting an equivalent exam to the RPSGT from a certifying agency. But what I saw most commonly in these 12 practice acts was that there was an exemption from this licensure requirement for respiratory therapists. Now remember, only 12 states had specific regulations for polysomnography. For the remaining states, the regulation links on the AAST website actually bring you to each state's Respiratory Care Act. And interestingly, the majority of the Respiratory Care Acts have exemptions allowing non-RTs to perform sleep disorders testing. So you can see this intertwined relationship between RT and sleep, which goes way back. And it's going to continue due to the overlap in our clinical duties. It appears that RTs are really protected to practice sleep medicine currently, but just keep in mind that there may be lobbying going on behind the scenes, and we need to keep an eye on any regulatory changes coming down the pike. Luckily, the NBRC has the resources to continue ensuring that the SDS will meet Medicare accreditation and licensing requirements. In 2016, we caught a Medicare LCD stating only RPSGTs could score home sleep tests. And we set about working with the medical board of that MAC to get the SDS added to their language. The CMP process we've discussed is not only efficient, but I would say that it's effective. It will ensure that you gain knowledge relevant to sleep disorders. The questions are based upon the current job analysis results and focus on areas that have a potential for high risk or that change rapidly. Having personally managed a sleep lab accreditation application, I had the task of manually entering 30 CEUs for each tech working in the lab. And I can say that I saw a variety of CEU transcripts. The NBRC CMP process will ensure that your ongoing education is directly related to changes in the field, and it will provide a variety of assessments based upon the entire exam content outline. The financial benefits of lower exam and recertification fees, combined with the NBRC's social purpose programs and advocacy for the profession, will reach well beyond your own pocketbook and help move our profession forward. I would encourage respiratory therapists working in sleep medicine to be aware of their Medicare local coverage determinations around sleep disorders testing. I discovered changes in the policies when I reviewed them for this talk. They change without notice, and they can dictate minimum technician credentials. There's a really good link on the AASM, the American Academy of Sleep Medicine website, where you can click and check every LCD that affects sleep disorders testing in the country. Very user-friendly. Now I'd like to spend some time addressing RTs that don't identify as currently working in sleep medicine. I'm hoping to make the case that we all work in sleep medicine these days. Due to the changes in patient awareness, media campaigns, and national guidelines around sleep, we are much more immersed with information than 10 or 20 years ago. When I started as a sleep tech over 20 years ago, the majority of my patients did not know what a CPAP was. But that is not the case today. And general sleep literacy is increasing as quickly as technology. Just think about the data you can get from an Apple Watch. I chose this ad for QUVIVIQ, which is a newer insomnia medication, because recently, in one day, actually it was in the morning of one day, I saw it on LinkedIn, Facebook, and The Talk on TV, where Ms. Vaughn insured QUVIVIQ was mentioned. It has truly become routine to hear or read something about the importance of sleep on almost a daily basis, which is great. How many of you have seen this ad? It could be my geographical location near Minneapolis, the headquarters for Inspire, but I see TV and hear radio ads on a daily basis for this product. And the advertising is working. Patients are presenting to the sleep lab requesting this implant before they even have a diagnosis of OSA, or have even tried and failed CPAP, which is a prerequisite for the implant. So the impact of advertising on the general public is very clear and on the rise. How about articles like this one? With the link between sleep and dementia becoming more certain as research advances, this article and many more like it are increasingly drawing attention as dementia is touching the lives of our loved ones. When I recently plugged in an online search, how does sleep affect dementia? I found readily available, relevant, patient-focused information on websites such as AARP, Mayo Clinic, Sleep Foundation, and WebMD, just to name a few. There were more YouTube videos about the subject than I could even count. The research emerging about just how busy our brain is, quote unquote, cleaning house while we sleep is really fascinating. And I can tell you that this particular aspect of the consequences of OSA is more motivating to many patients than their hypertension. If treating OSA can potentially prevent dementia, they are on board. So our patients have easy access to multiple sources of information that are popping up in their Facebook feeds and arriving in their AARP magazines. Several years ago, I developed a staff and public education talk entitled The Forgotten Third. It focused on the importance of sleep in our lives. But now I feel like this third of our lives has come out of the dark, so to speak, and is no longer forgotten by the general public. I see or hear those ads for Inspire or insomnia medications on almost a daily basis, and celebrities like the ones listed here openly discuss their issues with sleep. An astonishing number of Americans turn to the internet with inquiries about their sleep, almost 5 million times a month. And last year, the American Heart Association added sleep duration to their Essential 8 scoring system for cardiovascular health. Sleep duration now ranks up there with diet, tobacco use, exercise, and blood pressure in determinants of cardiovascular health. Hopefully, just like the food pyramid, our patients will become accustomed to viewing sleep as a priority in their lives. This decision was based upon the results of the Sleep Heart Health Study, utilizing 10 years of data from over 5,000 participants. Results revealed that short sleep duration, both objectively measured and self-reported, was associated with increased all-cause and cardiovascular mortality. And just to give you an idea, of the 1,172 participants who died from all causes during the 10-year study period, 45.9% displayed an objective sleep duration of less than or equal to 4 hours, compared to 13.5% who slept 7 to 8 hours. This study reaffirms that we need to focus not only on treating sleep apnea, but ensuring our patients have adequate sleep time. It also confirms that the sweet spot for sleep duration remains what we've always known, 7 to 8 hours. This is something we should all keep in mind as caregivers who need to take care of themselves. So you can see why our patients are presenting for care with a higher baseline knowledge about the value of their sleep and higher expectations from their treatment team. But isn't it enough that RTs have a good basic understanding of sleep disordered breathing? So in an attempt to explain the interconnection of multiple sleep disorders, I discovered an analogy many years ago, which has worked well with my patients. Sleep is like an onion, and we sometimes need to peel away a few layers of sleep disorders to get to a good night's sleep. While treating sleep apnea is certainly a large piece of the puzzle, if our patients are suffering from chronic insomnia, a limb movement disorder, or a parasomnia, they may not fully benefit from CPAP therapy until we peel away or treat those other layers as well. The International Classification of Sleep Disorders lists more than 60 different disorders divided into 7 categories. And while I am not proposing that RTs become experts on 60 different sleep disorders, it is time for the healthcare team to look beyond the upper airway for ways that we can improve the sleep of our patients. Remember, restorative sleep requires adequate quality and quantity, so we need to focus on both. With 1 in 3 adults meeting diagnostic criteria for chronic insomnia, and about 50% of us affected at least occasionally by difficulty sleeping, one could argue that this should become a focus. While medications get the advertising dollars and public attention around insomnia, did you all know that cognitive behavioral therapy is actually considered the first-line therapy? Almost half of us admit to short sleep duration, which, as I've mentioned, is now known to be associated with increased mortality. And just like other medical conditions, the incidence of most sleep disorders increase with age. You can see by the numbers here where that population is headed. So with our aging, sleep-deprived, increasingly educated population, it will become more and more important that there are caregivers with a good understanding of the importance of sleep and treatment options for various sleep disorders. Achieving the SDS credential could help provide this foundation. Even the title, Sleep Disorders Specialist, implies that you can do more than just diagnose and treat sleep apnea. OSA is certainly the responsibility of RTs working in various settings, but even serving as the resource for OSA is not as simple as it once was. we have a pretty good handle on the increasing prevalence of OSA, its association with age and weight, and the need for more testing, as the vast majority of our patients, around 80%, are yet to be diagnosed. But have you had the chance recently to read about the consequences of OSA? It's not just associated with hypertension and atrial fibrillation anymore. Are you prepared to answer patient questions about how OSA impacts their immune system, the development of diabetes or dementia? Patients are becoming their own advocates and will come to the table ready to discuss sleep. Once you determine that a sleep study is probably needed, should the patient have an in-lab study or an at-home study? Patients who have had a meaningful discussion about OSA in the hospital present to the sleep lab generally more open to testing and the treatment process. One thing that is really helpful is if you can describe the testing process in some detail. What type of HST does your sleep lab utilize? Is it a standard type 3 that looks at airflow, effort, and SATs? Does your sleep lab utilize one that looks at peripheral arterial tone, or is it a single sensor on the chin or the forehead? For those patients that have been tested in the past, did they order their study online or through a dentist? Can you find and interpret the report in the electronic medical record? These are all questions that might arise during an admission. When your patients present with their home machine, is it a CPAP, a BiPAP, an ASV, an AVAPS, an AVAPS AE, or are these even the names of the modes on the machine you are responsible to apply? And no, CPAP is not a substitute for all of these modes. What do each of them do? What options do we have if no CPAP is available during the admission? Is the machine a brand you recognize? Due to a large national recall and supply chain issues, we now need to be comfortable with new technology. If a provider requests a download during the admission, where can we get this information? If your patient pulls up a download on their phone, can you make recommendations based on that information? The SDS could help provide the foundation to work through these situations and emerge on the other side as the patient and provider resource around sleep. And speaking of new technology, these are just a few of the examples of treatment options available for your patients with sleep apnea. And I do mean just a few. As the public becomes more aware of their sleep, the marketplace is rising to the occasion with many more options, both surgical and non-invasive. With most devices and procedures requiring a prescription, others are over the counter. And you may well encounter patients who have taken matters into their own hands, but are they well treated? There is a whole new population of patients who could benefit from some follow-up questions, such as, have you been retested to ensure your OSA is well treated? Are your symptoms resolved? Does your bed partner hear snoring or pauses in breathing? Let's take a couple minutes to just introduce these options. Again, not an all-inclusive list, but a good start. In the upper left-hand corner, there's an example of an oral appliance. These move the bottom jaw forward in an effort to prevent the tongue from falling back and collapsing the upper airway. These are designed for patients with mild to moderate OSA. Some are adjustable, and they may require a morning repositioner to recalibrate the normal position of the teeth and lower jaw. Shown in the middle on the top is an intermittent negative airway pressure device. This is a small cordless unit that applies a negative pressure through a mouthpiece that sits right behind your teeth. This pressure pulls the tongue forward during the night, again in an effort to maintain patency of the upper airway. The size and cordless features make this one kind of appealing, and the company actually has a picture of a patient using it on a plane. Pictured on the top right is a device that provides daytime therapy to strengthen tongue muscles. This is used for 20 minutes during the day, and it delivers targeted neuromuscular electrical stimulation to tone the upper airway muscles and prevent them from collapsing. It's designed for mild OSA and snoring and provides one of the only options for daytime use. Positional therapy devices like the one shown on the bottom left are meant for patients with positional sleep apnea, which occurs when the majority of apneic events and snoring occur while in the supine position. While sleep apnea is generally worse in the supine position for most patients, for some, there are very few events when lateral, and staying off their back is effective. We used to tell patients to sew tennis balls in a pocket in the back of their t-shirt so that rolling on their back was a nuisance. But as with all other advancements in the sleep market, it makes sense that devices for this population have emerged. While some of these take on the tennis ball theory and are worn around the abdomen to prevent rolling supine, others have a quote-unquote gentle vibration alarm and can be worn around the abdomen or even the neck to prompt patients to remain lateral. Moving over to the bottom, middle, and right, we see implants for both obstructive and central sleep apnea. These are gaining traction as payers increasingly approve reimbursement. Unlike most other devices that we've mentioned, the OSA-focused device, also known as a hypoglossal nerve stimulator, is surgically implanted and meant for moderate to severe OSA in adult patients. If you have a patient admitted with one of these, it would pay to ask if the remote is present and consider compatibilities if MRIs are ordered. I can tell you that from the volume of advertising, you will be seeing more implants in the future. A good understanding of these devices, which may be coming into the hospital with your patients, is very important to their care. The RT may be the one who observes the need for adjustments to treatment or the need for further testing. OSA evolves over the lifetime and requires ongoing attention. CPAP may need pressure adjustments, and a device that worked well 10 years ago may now allow your patient to snore loudly and desaturate repeatedly. What about those patients who failed or refused CPAP in the past? A knowledgeable RT could be the bridge to one of these alternative therapies. I've always encouraged RTs and sleep techs to revisit the conversation about treating OSA because you never know when a patient will be ready to retry therapy. Much like tobacco cessation, we shouldn't just accept a no thank you as our patient's final answer. Okay, so hopefully you can see that there is a need in healthcare for a broader understanding of the importance of sleep, sleep disorders, and treatment options. But why should RTs take this on? And here's my question for you. If not you, then who will address sleep when our patients are admitted? There are certainly navigators who can see these patients, right? Well, maybe, if you're lucky. In 2019, of 6,090 U.S. hospitals surveyed, over 3,000 of them, or 56%, had less than 100 beds. Small hospitals do not generally have easy access to sleep, COPD, or respiratory navigators. And in my experience working in rural healthcare, there may not even be a pulmonologist on site. With the drive for increased efficiency in modern healthcare and the improvements in telemedicine since the pandemic, rural hospitals are increasingly depending on remotely located physicians who cover multiple hospitals overnight. Yep, that means there is no physician in the hospital overnight. And when you do have a hospitalist available, they are probably looking to you for advice. on your patient's sleep-disordered breathing or other sleep disorders because they received less than 2 hours of training in medical school. I've fielded many a call over the years from our hospitalist team with questions about what settings or tests to order for their patients. I can tell you from experience who will likely be on site 24/7 in hospitals of all sizes, NRT. During a very short 2-year period of managing the RT department in our rural hospital, I never received more calls or pages than when the one RT that was scheduled to work called in sick. The RTs are truly one of the most valued team members in the building, and we are uniquely positioned to help improve the quality of our patients' lives by becoming the resident resource around sleep. So what do providers want from RTs? I was extremely fortunate to work for over 18 years with a medical director for our sleep lab who functioned in a dual capacity as a hospitalist and a boarded sleep physician. She also has a reputation as a tireless advocate for her patients. And while I made many trips to the hospital rooms over the years to answer patient questions or provide a mask fit, this close relationship between the sleep lab and the hospital served us very well. I contacted her recently as I prepped for this talk, and I asked her the following question. What could an RT with the SDS do for you in the hospital? And this is what she said. She wants RTs to be able to comfortably answer patient questions about their symptoms, treatment, and the importance of sleep in their lives. That means we need to keep up with the current pace of information. She wants us to consider sleep history and treatment decisions. Just a few examples were, what EPAP should I choose for a respiratory failure patient with a known history of OSA? How are we going to treat OSA during this admission? Or what RAD guidelines, respiratory assist device, can we meet before discharge? Her moonshot would be a collaboration with RTs around sleep initiatives outside the sleep lab. Some examples of programs that we developed together in the past were a no-wake zone, aimed at decreasing sleep disruption for stable admitted patients. So we all know that sleep is challenging at best during an admission. We developed a clinic-based perioperative screening program in an effort to prevent adverse outcomes, and an inpatient screening program for OSA that was led by our RT department. I'm sure there are many more great ideas out there for ways that we could collaborate to improve our patients' sleep. But these were programs implemented in a small regional hospital with no pulmonologist and no navigators. What we did need was buy-in from the RT department for success. And I believe that achieving the SDS credential could assist by providing the confidence to make sleep just a natural part of our daily patient and provider interactions. So we started with a brief history of RT and sleep medicine, and I thought it would be appropriate to discuss just a couple future directions as we wrap up. I don't think it's any secret that more and more patients are being tested in the home. Whether you love it or you hate it, home sleep testing is not going away. Our patients save money and enjoy the convenience of completing studies in their home, but they miss out on the interaction and education provided by the night technologist. With testing available via dentists, online vendors, or maybe even through your employer, some trucking companies develop their own testing programs. You may very well encounter patients with a diagnosis of OSA who have never had a consult with a sleep provider. Your patient might pull up their sleep study results on their phone and ask you to help them understand the data. Even when patients are tested through accredited sleep centers, a certain percentage never return for their results. They are mild at their initial diagnosis, or they decline treatment when it's offered. So it stands to reason that you may be caring for these patients in the hospital due to the downstream consequences of untreated OSA. That admission might be the tipping point where your patient is ready to treat their OSA. But who will be comfortable discussing their diagnosis, treatment options, and benefits to their health? I hope you can see that the need for providers in the hospital who can educate and support these patients toward treatment options and further care is very important. Artificial intelligence may seem like a really odd topic for this presentation, but its future in sleep medicine is gaining momentum. The use of AI in the scoring of sleep studies has been around for several years now, and it's gaining traction as the AASM has an entire committee dedicated to review advancements in AI. They have also launched a pilot program to independently verify the performance of auto-scoring systems, and there are 3 webinars and a position statement related to AI on their website. One of the leading AI companies centered around sleep is paving the way with no less than 26 webinars offered on their website. These are well marketed, as I've personally have been motivated to attend 2 of them, and I'm registered for a 3rd. I have to say that their case for the value of AI in sleep medicine is compelling. Just imagine a future where AI could identify patients at risk of OSA through the review of potentially millions of electronic medical records, then prioritize this population by risk for adverse outcomes, and ultimately assist in a quicker, more cost-effective diagnosis with AI-assisted scoring of their tests, all without adding staff. So what does this mean for RTs? I would argue that we are uniquely qualified to integrate data from multiple sources to make decisions about the best care for our patients. That's what we learned in RT school, right? With our baseline knowledge and real-life experiences working in multiple areas of healthcare, we are poised to not only exist, but flourish in this future data-driven environment. And RTs with a strong sleep medicine foundation will be positioned to provide leadership as artificial intelligence propels the sleep field forward. So as we wrap up, I'm hoping that I provided some insight into what the SDS credential could do for you. If you're an RT working in sleep medicine with increasing regulatory requirements, the desire for credential maintenance efficiency, or hopes to advance your career, the SDS can help meet your goals. For those working outside the sleep lab, becoming the resource for patient and provider questions about testing and treatment of a variety of sleep disorders will increase your value to the healthcare team, improve patient experience, and potentially affect outcomes. Another consideration is future career options. We often begin to consider other career paths later in life, perhaps ones with no holidays or weekends. And the SDS could set you up for a transition to sleep medicine, DME, care navigation, or even industry jobs. So I'm hoping that I have provided some insight into ways that the SDS can benefit RTs working in and out of the sleep lab. I really appreciate your time and attention, and I would be happy to do my best to answer questions at this time.
Thank you, Laura. That was an amazing presentation. I do have actually a couple of questions in the chat that we hopefully can get to here. So the first question is, has the presenter reviewed the LCD changed by Palmetto GBA that an RPSGT must review/rescore the data of type 4 devices? So that's the first question.
Actually, yes. The Palmetto LCD, and I'm not sure that we're talking about the same thing, but they say, and type 4 devices would be a home sleep test. And that particular LCD right now only states RPSGT, but we're working on it. This happened back in 2016, and the NBRC addressed it. And so I think in the near future, you're probably going to see a change there. That's one of the things that we really try to keep an eye on, and we really want to hear from RTs if they're being excluded from practice in any areas. So yes, I am aware of that. Thank you.
Great. And then another question came up is that having sleep labs are going out of business and physicians are increasingly not interested in getting trained. How do you have any idea of how to make the ROA argument to get hospitals interested?
Oh boy, that's a tough one. I mean, I know that there are fewer sleep labs, partially because of the home testing advent. But sleep disorders are huge. We have such an underdiagnosed population out there. I guess if it were me, I would try to put together a case like this. You know, how many patients are out there? How is it going to affect their health down the road? How are we going to actually save money? If you're looking at taking care of a population and treating and taking care of their medical needs in the most cost-effective manner. Yeah, that's a hard one. I'd have to kind of think on it, but I would put as many statistics together as I could and hope that we could find a way to really propel that forward and get people to enter that area.
Great. Hopefully, Francis, that helped answer your question. And I think, Laura is a great asset and certainly can reach out to her if you're needing kind of to formulate some ideas. And then the last, probably last question for the day is many of our inpatient providers order CPAP for suspected CPAP without considering, or for, I'm assuming a suspected OSA without considering underlying areas affecting sleep. Those being patients being placed on CPAP for the first time affect their sleep in the hospital. How do you address these MDs ordering CPAP?
That's a good question. I mean, I see pros and cons, right? If that patient can experience CPAP and they've had moderate to severe OSA for years that hasn't been treated, it could be just a life-changing thing for them. And they may very well be just so excited to go and have their sleep study and get qualified. But I agree that the first night on CPAP is not always the best. I wear a CPAP at night. I'm a personal user. So I guess you got to give the doctors props for thinking about it, right? And for wanting to put the patient on it. I think a lot of them just want them to experience it, want to have a taste of it, to understand it before they ever leave. And I really don't think that's a bad thing. One thing that might be good is if, you're going to try it, and I really don't think that's a negative. But if you're informed and understand that you can coach that patient and say, this may not have gone great tonight, but that doesn't mean that it isn't going to go great in the home. Don't make a final decision based on this one night in the hospital when you weren't feeling well. That's the type of coaching that I think could really make a difference. And you can go to the doctors and talk to them about how challenging this might be. But I guess I would argue maybe look at it as an opportunity to expose those patients, even if it doesn't go great, and then coach them on the fact that it doesn't mean it won't go well once they get acclimated to it in the home.
Great. Thank you, Laura. We are out of time and did not get to all the questions. We can gather the remaining questions and provide answers and send them out. Thank you again for joining us today. And Laura, for such an amazing presentation, and thanks for all who attended today's webinar. We do have a couple of upcoming AARC events, so please join us for the next broadcast on April 21st for the April Respiratory Care Journal Cast. And then also on April 25th, the AARC will be hosting a special live panel for students and educators that will include a presentation with the AARC President Hinkson and the CEO Daniel Garrett, a personal testimony and questions and answers with the AARC Executive Office leadership It is open to all AARC members and non-members. Thank you again and have a great day.
Thank you so much, Joyce. And again, thank you, Laura, so much for your presentation. And thank you to all for joining us today. If you are a group participant, please make sure to have your group leader submit your information to the group attendance tab so that you can be provided with follow-up instructions on how to submit for credit. If you have any questions, please email crce@aarc.org. This does conclude today's presentation. Once the course is marked complete, the system will automatically submit credit for you after you've completed the survey. You can check the status in the credit submission tab. We all hope you have a great afternoon.